All right. So this is a talk I actually gave to our primary care sports medicine conference in December. And it was originally based on a talk around cyclists, but that part comes in at the end. Let's see here. So I have nothing to disclose. So mainly we talk a lot about management of arthritis. That's just a little bit about me. I'm current team physician for the San Francisco Ballet, a women's pro cycling team, Marin Academy High School. I've done a lot of travel with some elite Olympians from Canada, the Canadian ski team, Canadian women's basketball team, and done some quite a bit of event coverage as well. So objectives, just understand history, physical exam, and x-ray findings of osteoarthritis, discuss the latest ORC treatment guidelines, and the evidence to support conservative treatment, and then understand when it's time for surgical treatment, and look at a few case studies if we have time. So osteoarthritis. Let's see here. This is a good quote. Time is a great teacher, but unfortunately it kills all its pupils. And so osteoarthritis has probably less to do with inflammation, which is a secondary result, and more to do with programmed cell death as we age. We found an increased proportion of apoptotic cells present with age and in rotator cuff tears and tendons that are degenerative. And I think there's still a lot more to learn about this, but there may be some stress-activated protein kinases that affect collagen repair, and that may increase as we age. And then this all sort of leads to osteoarthritis, which, as you know, is a disease characterized by cartilage degeneration. And cartilage loss and osteoarthritis symptoms are preceded by usually asymptomatic damage to the collagen proteoglycan matrix. Now, sometimes there can be trauma and it can be symptomatic, or there's overuse for mechanical problems, and there's probably a big genetic component that I still think we don't know a lot about. So arthritis is very common, as I'm sure you've seen along the way. I think a lot of bread and butter orthopedics is managing arthritis, kind of like patellofemoral pain. Knee arthritis in our aging population is super common, and you'll see a ton of it in your clinics. These are the latest stats from 2019, and they've increased from the previous stats that we used to quote. But 24% of women, 18% of men have osteoarthritis, and almost half of people with arthritis have limitations of their usual activities due to the arthritis. Osteoarthritis is the most common form of arthritis in the US and only is going to keep increasing as our population. Let's see here. Sorry, I'm in trouble. So risk factors for arthritis. So previous joint injury, overuse, repetitive microtrauma is essentially overuse, microtrauma to the cartilage, loss of proteoglycan, loss of water content over time with repetitive microtrauma continuing leads to degeneration. Age, of course, is the biggest risk factor. Certainly see arthritis at younger age as well. Gender, as you saw from those earlier stats, women have it more commonly than men. And then obesity, probably the extra stress on the joints from the heavy weight, and then also metabolic effects that increase the loss of cartilage. Genetics, I think, is a big one. I recently saw a lady in her 50s, and she had 3 different joint replacements. She had severe shoulder arthritis, both shoulders. She was in her 50s, and there was no explanation other than her mom had the exact same thing and one of her sisters. So it was quite interesting. Sometimes you see this in families where there's very early arthritis. Race definitely can play a role. We've found that Asian populations often have lower risk of arthritis. I think that's multifactorial as well. And just to kind of bring in a little bit about care here for knee arthritis and some recent evidence citing disparities in care of arthritis. As you may or may not know, knee arthritis disproportionately affects underserved populations. And people of color have scored higher on pain scales than white Americans. And so, do the underserved have more severe OA, or does it go for longer before it's diagnosed? Or are there more external factors that aggravate the symptoms, that increase the pain scales, that affect function? It's very multifactorial and not totally understood at this point. But a recent study in 2020 just came out and Kavanaugh et al. Found that Black women had significantly poorer function than white women in the decades before and after knee replacement. And Hispanic women, they looked at the 3 different categories, were similar to the white women. And this was a cohort study with many, many patients. They looked at women in the WHI over many years and looked at physical function scales, self-reported activity limitations. Typically the physical function are things like step up, walking distance, and then stepping up and down for several minutes. Another recent study also found that Black patients with knee osteoarthritis had poor outcomes and scores on the physical function tests than Caucasians. And so that's sort of a whole nother topic, but I think very multifactorial and sort of plays in a little bit to when we talk about treating this. So first we'll start with diagnosis. So first of all, history, fairly classic for arthritis, pain, swelling, and mechanical symptoms. Now, some of those can come later. Stiffness can come later, morning stiffness, stiffness without activity, and eventual deformity. And so we've all seen people on the street and in our clinics with knees like this, with the varus deformity on one side, sometimes on both, sometimes valgus. And those are late findings. Crepitus is very common. Sometimes there's very loud grinding with or without pain, loss of range of motion, and of course, bony tenderness. So knee pain, stiffness, swelling, plus or minus mechanical symptoms, which, as you know, can come with other issues. So if you have those and you're worried despite their age, you definitely want to get weight-bearing views, including Rosenberg views. I always get bilateral Rosenberg, bilateral Merchant, and then lateral weight-bearing views as well. So the weight-bearing is important, and not every X-ray facilities like UCSF will do them automatically. So you want to make sure you ask for those. Just some X-ray findings. Mild arthritis shows mild, my cursor's gone, but mild joint space narrowing, moderate, more joint space narrowing, squaring of the tibial eminence, and then loss of joint space and severe arthritis. So these are Fairbank's signs, and he described changes in knee X-rays following meniscectomy over time, particularly the squaring of the joint of the condyles and the prominence of the tibial eminence with ridging, and then the joint space narrowing. And here you also see sclerosis, which wasn't what he described, but is part of arthritis. Diagnosis we make on X-ray, which includes joint space narrowing, osteophytes, and sclerosis. So MRI is not necessarily needed to diagnose arthritis. I think it's definitely good at finding early changes, but typically we base our grading systems on X-ray findings, and these are just a few that are listed. There's different grading systems, as you know, which do or do not correlate to patient symptoms. Okay, so this is what we sort of want to get into, is how we treat arthritis. And there's a lot of new updated good guidelines. This is the AAOS, as you all know about, and the guidelines were all updated in 2019. And they're updated every 5 years, and they do change. So primary treatments include home exercise program, plus or minus formal physical therapy. We'll talk a little bit about NSAIDs versus acetaminophen and injections, weight loss, activity modification. And so this just sort of goes through the different options of non-surgical management, which should all be included in the treatment plan. And so this is kind of a good slide. I think one of the most important things with arthritis is actually diagnosing the arthritis in the first place. Sometimes it's obvious the patient's older, they have deformities and horrible X-rays, but it isn't always that obvious, especially when they first come in, if they're younger. And then I think the big thing with treatment guidelines now is looking at the whole patient and the whole picture. And even though you're just maybe treating their knee or their hip, you have to consider their comorbidities, their function, a little bit of their socio-emotional environment, and what they will do for treatment. And so this slide just sort of says, have them come in, select an initial treatment, start with that, have them come back, reassess, which is all good medicine and we should be doing anyways. And sort of starting through the hierarchy of how we treat them and reassess and tweak it as needed. Okay, so the ORC guidelines for the non-surgical management of knee, hip, and polyarticular arthritis from 2019. So the last guidelines were published in 2014 and were a little bit different. And they sort of organize it differently and change recommendations. But the big thing for all forms of arthritis is what they call the core treatment. And so for knee, and they've split it up into knee, hip, and then polyarticular. And so the core treatments for all of them, but this one's especially for knee here, is education number one. So I think the most important thing is setting expectations for these patients. And even though we know just inherently osteoarthritis is degenerative and it doesn't get better, I think a lot of patients have trouble understanding that initially, especially when they're surprised with their diagnosis, and they have trouble understanding that it's not going to go away. And so really educating them on what they're, what the diagnosis is and how we're going to manage it. We're managing it. We're not necessarily going to cure it. And we can manage it well. And it doesn't mean they're going to be debilitated all the time, but it just means that it's going to be with them. And so the core education, land-based exercise, so strengthening cardiovascular, neuromuscular, balance type activities, or Tai Chi is mentioned a lot in this, so it can be quite helpful for balance and movement. Those are all included for all patients, so we start with that. And then the number one recommendations for knee arthritis, so category 1A, and this is recommended for every patient, is topical NSAIDs. And we'll talk about that, but there's been some studies that show moderate benefit over 12 weeks and a decent quality evidence, minimal side effects, and that's for the knee alone. And so they break the arthritis down into if it's just the joint alone or if they have comorbidities such as gastrointestinal problems or other joints. And then if that doesn't work, you go to 1B, which is recommendations that we would recommend without hesitation: aquatic exercise, cognitive behavioral, self-treatment programs, NSAIDs with or without PPIs or COX-2s, depending on their cardiovascular status, and then looking at injections, which are also 1B, intra-articular hyaluronic acid and cortisone as well. And then there's additional recommendations for Cymbalta, intra-articular cortisone, depending on the situation. And I encourage you to look at these. They are really thorough and actually quite helpful. And so certainly if you had complicated patients, you could kind of go through this and say, well, where am I at? I'm struggling. Okay, it says here cognitive behavioral therapy. Oh, great, I'll send them off here. Or pain management, someone with frailty at the end there. And so you sort of start at the top, the core, everybody gets that, and then the 1A, and you kind of work down. And these are, easy and clear for knee, but it gets a little more complicated when they're multi-joint and there's other comorbidities. Okay, so talk a little bit about hip. And so the core treatment for hip is land-based exercise and education. So it differs a little from the knee. And then there's no direct evidence for any 1A recommendations for the hip. So then we'd skip to 1B. So it's not as clear as for the knee. And that would be NSAIDs, hopefully COX-2 if you can, if not with PPI. Oh, sorry, that's level 2. Tai Chi yoga, gait aids, and then level 2 below that, NSAIDs, PPIs, COX-2, and then CBT. So sometimes we have to integrate other treatments. There's lack of direct evidence for any group for weight management, but they do have these statements that say, well, it's good clinical practice and that we should talk about weight management for different individuals, but that certainly can play a role in treating osteoarthritis. Sometimes it's catch-22 because they have too much pain to exercise enough to manage their weight. And so sometimes you're sort of balancing, how do we calm their pain down, get them stronger, get them moving, get their weight down, and so they can sort of manage this until they need to have surgery. NSAIDs are conditionally recommended for hip osteoarthritis without comorbidities, and preferably with a PPI. So then there's recommendations for polyarticular arthritis. Again, they're not as clear as they are for knee. Core-based the core or land-based exercise programs. There were no 1A recommendations. And then 1B were things like gait aids, Tai Chi, self-management, weight programs. And then you go to medications, NSAIDs with PPI or COX-2s, topical NSAIDs if they have GI comorbidities, depending on what those are. Injections weren't found to be as helpful for polyarticular, obviously, because there's more joints and it's harder to manage those. And sometimes you need to pull in pain management or CBT. And sometimes I think they had Cymbalta, Duloxetine was a medication indicated, on and off depending on the year. So things that were not recommended for knee, hip, or polyarticular osteoarthritis. So interestingly, in 2014, Tylenol was recommended, and it's now come off the list. So Tylenol is not recommended, and then stem cell or PRP is not recommended as well. So then we sort of go into this briefly. Each level. So lifestyle, reduce weight, reduce the pain producing activity, change sports, low impact, use a cane or a brace. I'm a huge advocate of cycling for knee arthritis. Luckily now a lot of people have Pelotons and indoor bikes, but even if not, I try to get them outside. I think e-bikes are much more popular now, and some of the older patients can handle that a little better, but just getting the knees, especially moving without impact helps with pain management. And so sort of talking to them about, well, how can we integrate these non-weight bearing treatments to lubricate the joints with your normal activity? So we want to reduce the impact across the joint as much as we can. So shoe wear is a little controversial, and I just added a question mark after shock absorbing shoes because I was just on a lecture about gait, and the big thing they were saying is that the number one change in gait treatment is shortening the stride. And what the latest research has found, all these cushioning shoes, the cushioning is helpful for foot and ankle probably, but it doesn't translate up the chain as well. And they were saying if you're in a heavy shoe with a big heel counter and lots of support, you might sort of strike more heavily or run or walk harder. Whereas if you were running barefoot, you'd run a lot more gently. And that they found when they did analysis translated to less stress on the more proximal chain joints. So I think shoes a little bit questionable, but what I think is important is looking at the arch supports, the wedges. So, if they're varus, you want them, so they're compressing their medial compartments, you want them to pronate more to open up those medial compartments. And so you take out all arch support and have them pronate more to open the inside up. So just educating them on things like that. Sometimes we'll cut heel wedges to make them more varus or valgus to unload one compartment. And orthotics can be helpful as well. So this is just demonstrating how the wedges can actually change the alignment a little bit, and they're much more tolerated than the unloader braces, which we're going to talk about now. These are helpful. I think there have been some good studies to show that they can help with pain and function. I think, depending on the patient, they're big and clunky, and so some people don't tolerate them well. But for things like tennis, if they have knee OA and they want to play, they can be quite helpful, or for skiing or for weight-bearing activities. Obviously, they're not needed for things like cycling. This was just one study that showed the effectiveness of offloading braces in medial compartment knee osteoarthritis, and that the unloader braces were more successful at reducing pain than neutral braces or neoprene sleeves. But there was poor compliance. So again, it sort of comes down to compliance for these 28% at a year, not great. So number one, conservative treatment, rehabilitation, stretching, strengthening, pain-free range of motion. So joints like to move. They like lubrication. They like cushioning. They like fluid movement. And so just trying to get people moving their joints as they get arthritic and have less water content, I think is really helpful. Physical therapy has been shown in the literature to work. I think part of it is also important in helping these people with their function as they get older. despite the arthritis, which we know we can't cure. We can teach them to take care of themselves, and the stronger they are, the better they're going to manage their sore joints. So physical therapy works. Numerous studies have shown that exercise is better than nothing. And there's different types of exercise. This one from JAMA 1997 showed they randomized to aerobic versus resistance exercise versus nothing, and looked at outcomes with pain. And they saw significant improvements in outcome measures, which was pain and function with the exercise groups. And of course, it worked best in those with mild to moderate arthritis, who are probably a little more manageable. And so we know that weight programs are effective, and they're effective for many things, not just arthritis, certainly for maintaining strength and muscle mass as we age. This is just a study that showed that AMSSM, American College of Sports Medicine position statement, the recommendations for strength training in an untrained adult, sort of sets of 10 to 15 reps, each major muscle group, slow, moderate velocity. So we sort of stressing strength gains has been the most beneficial. Tai Chi is included, and Tai Chi works very well. It's much more popular in some Asian cultures, but certainly focuses on balance and motion, can improve quality of life and help circulation, help reduce falls. So what if you have a patient with knee arthritis and we're recommending cycling and they have pain to ride? Well, then there's some things you can think about in how can we fix that, because we're still not weight bearing with riding. So if we can reduce the pain, the cycling is good, even if there is some arthritis in there. So you can look at bike fit, you can change the seat position. So if the seat is low and forward, that puts more pressure on the patellofemoral joint. We can look at the cleat alignment. And I think that's something that's come up with Peloton now, is that people, when they first get it, if they're not set up properly, the cleats, I don't have one, but I think the cleats are fixed in a little bit of a funny position. And so that can generate knee pain when people first start on their Pelotons. We can put wedges in the cycling shoes to affect the alignment of the knee. If they're in flares of knee pain, you can have them just spin without too much intensity. And then you can do physical therapy to improve their stability, their core strengthening, stretching, because if they're just cycling, it's very one-dimensional. And you can add different sports, Tai Chi, stretching, swimming, things like that. You can add NSAIDs, as we talked about, topicals first, and then PO, depending on their comorbidities. So conservative treatment is really NSAIDs, analgesics, and then injections. So just a little bit about acetaminophen. As you know, it's an analgesic, an antipyretic. It used to be recommended as first-line treatment for pain and osteoarthritis, and in a lot of primary care settings, Tylenol was given for everything. And it's interesting how that has changed over time. And now the use of Tylenol is actually conditionally not recommended. And so it's level 4A/B, so it's way down on the list, and it's not recommended for osteoarthritis. So the main risks being liver failure and increased risk with consumption of 3 or more alcoholic drinks per day. And that, of course, is harder to control. And so I think that's part of the reason not to recommend it. Narrow dose to toxicity level, so it doesn't take much to put you into liver failure. And the general population aren't always aware of that. And Tylenol doesn't work that well, so they think, oh, I need to take more and more to get it to work. So in 1999, there were 500 liver transplants in the US due to accidental Tylenol overdose alone. So that's a big number. 4 grams is the absolute max. Appropriate dosing, 1,000 milligrams, so 2 extra strength Tylenol, they're 500 milligrams each every 6 hours. 3 grams is recommended max if risk of liver disease or failure. Again, it's not super high doses. 2 grams max if liver disease. So probably NSAIDs are better. They have better pain relief than acetaminophen and lower risk of overdose. So anti-inflammatory, analgesic, antipyretic, and higher patient preference. High clinical response, but significantly higher GI complications, as we know. There are different classes of NSAIDs, and they can all work differently on different people. So that's something that's important to remember. and there are variable responses to NSAIDs. And so if one NSAID from one class doesn't help, then you can switch them. So if they try Advil or Aleve for 2 weeks, usually you want them recommended, taking the recommended dose. So it's in their system for 2 weeks. If that doesn't help, you could switch to another class. Another class could work substantially better. And it varies person to person as well. However, the thing to remember is the same rule does not apply to toxicity. And so the longer you go, keep switching NSAIDs, you're increasing your risk of toxicity and GI side effects. And actually, you can even, people use Voltaren gel and take NSAIDs, you can still have GI effects, side effects from the addition of the Voltaren gel, even though it's not as risky as taking it orally. So 103,000 people hospitalized annually due to adverse effects from NSAIDs. This is from 2010, so it's a little while ago. 16,500 deaths a year. 25 to 30% of osteoarthritis treatment costs are due to adverse effect from NSAIDs. So that's pretty high, especially considering they don't work that great for, significant knee arthritis. I think there are equivalent treatments that are less toxic that probably have similar effects, such as exercise, physical therapy, ice, motion. So NSAIDs are risky. And what are the main risks of taking non-selective NSAIDs? So gastrointestinal, up to 50% of users have dyspepsia, peptic ulcer disease, bleeding, and then renal, up to carcinomas, hyponatremia, acute renal failure, depending on comorbidities, of course. Cardiovascular is the big one. They interfere with the antiplatelet effect of aspirin, so can lead to potential heart attacks. And then decreased platelet aggregation. So we have to, as you know, hold them pre-op and don't give them to patients already on blood thinners. Higher risk of side effects from NSAIDs if people are over 60, have other medical problems or histories of GI complications, peptic ulcer disease, or on steroids concurrently. So just things you kind of want to ask, even though you think, oh, I'm just treating their knee arthritis, but these are kind of things at the first visit you should definitely check into to figure out what you're going to treat them with. So if they have those things, you'd want to consider topical NSAIDs, a COX-2 inhibitor like Celebrex, which is easier on the stomach and cardiovascular system, and then the non-selective NSAIDs plus a PPI. So just a few quick studies, topical NSAIDs for knee and hand osteoarthritis, namely diclofenac sodium gel, Voltaren gel. You have to use quite a bit. It's not very strong, 4 grams, 4 times a day. I usually tell people 3 times a day. The other thing is that it's 2% in Europe, so it's double the strength and it's over the counter. So I always say, if you know anyone in Europe, they can send you 2% tubes, and it works much better. Pensed is another one. I don't know how widespread it is here. It's fairly widespread in Canada, and it's a little stronger and works a little better. And it's a liquid, so it comes out, they say 40 drops, but it's a liquid, so it's easy to get that much. And you just rub these on and then they sink in. And so the plasma levels of the drugs are low. There's no great head-to-head studies comparing adverse effects of oral versus topical, but really there's minimal side effects with topical. They found some skin reactions. And so it's first-line treatment now. This was a Cochrane review from 2012. Number needed to treat for the Pensed solution was only 6.4 and 11 for the gel, and that's the gel at 1%. And that was to achieve 50% pain relief over 2 to 3 months compared to placebo. So, it's safe and it works fairly well. Same efficacy of oral compared to topical. And so it's much safer to use the topical, especially if people have comorbidities. So it's always just, I think, worth asking people, because everyone just takes Advil, but there are risks with that, and you could prescribe them a Voltaren gel, and I think it does help some people. It doesn't help some people for sure, but you might as well try. There have been some increased skin reactions noted. I haven't found that, but I'm sure it exists. And then the GI events are less common. Now they can still happen. And so sometimes I'll warn people, don't double up this with all your oral NSAIDs, because you can still have GI side effects. So you say, well, why shouldn't we always use the COX-2 if it doesn't affect the stomach and it doesn't compete with aspirin the way the other NSAIDs do? Well, 2 examples of this: Vioxx, which was a great drug. I used to take it, worked really well, but unfortunately there were a lot of side effects, and it was withdrawn from the market in 2004. It was found to have increased risk of MI and stroke. in another trial they were looking at, and they found this. And so it was withdrawn fairly quickly. And then Bextra, which was also another NSAID similar class, was taken off the market a year later due to increased MIs in post-CABG patients, and as well as Stevens-Johnson syndrome. So significant side effects from those NSAIDs. And Celebrex has been associated with increased MI in 2 long-term trials, but it has been generally found to be fairly safe. And this was an article from the New England Journal of Medicine, 2016, that looked at 24,000 patients, and they were looking at adults with cardiovascular disease who took NSAIDs regularly for arthritis pain. And this is Celebrex 100 milligrams twice a day, so not 200 twice a day, which is the max dose, compared to ibuprofen 600 3 times a day, or naproxen BID. And all patients were given stomach protection with omeprazole. And they looked at primary outcomes, which was death from cardiovascular cause or non-fatal MI or stroke. And they found that the risk of those primary outcomes was not greater with Celebrex than with ibuprofen. Now, there was few limitations in the study, but it was a long study over 10 years. So they lost a lot of patients because it was so long. But generally, the question is it riskier than for cardiovascular side effects than Advil or Aleve? And I think that we don't fully know the answer to that. And like with any medicine, I think it's better to do the least possible amount and just do it for short bits. And so a lot of patients are on Celebrex, and I always sort of try to get them off if they're feeling better, come off of it, see how you do, and just take it for a week if you have a bad week, or take 100 twice a day instead of 200 twice a day, especially if they're sort of on it long term. And historically, we haven't given these COX-2 meds to patients with hypertension and diabetes and peripheral artery disease. But based on those those results from 2016, maybe they're safer than we thought. Again, I think we're not totally sure. And so trying all the other things is important, and trying to get them on the least amount is also important. So what about opioids, you say, because people ask for these. And so, as you know, they stimulate the central and peripheral opioid receptors, and they provide analgesia, sedation, they cause physical dependence, and they are strongly recommended against for osteoarthritis. So level 5, so even stronger than Tylenol, which makes sense. Recommendations against. There are some guidelines in UpToDate for opioid use and chronic musculoskeletal pain, stating that you need to make a careful assessment of the risks and benefits prior to starting. The treatment should be goal-directed, more short-term, to improve function and quality of life, and part of a multidisciplinary approach. So you try everything else as well. And there should hopefully be a care agreement, and only one prescriber, one pharmacy, some ground rules. I think, for that, it's all dependent on your relationship with the patient and how much you see them. And so it's tough to do that if they're seeing other doctors and have other caregivers. I definitely try to stay away from opioids as much as possible for osteoarthritis. And how about cannabis, the new one? So the recommendations are that it's not an alternative to the standard of care for any rheumatic disease. Many patients come in, as you know, asking advice about medical cannabis, asking for prescriptions, or they're already self-medicating for sleep, for pain relief. There are risks of side effects with these, and we don't really know if cannabis actually works. There haven't been great studies comparing it to other treatment methods. So I would sort of say do everything else. And then some people are just taking it anyways. I think the topical is probably harmless, and it never seems to work very well. In my experience, people say, oh, I tried it, it didn't really work, or oh, I tried it, helps a little at night. And so, okay, that's fine, as long as it doesn't displace proper treatments and recommended treatments. So how about injections? I like injections. I do tons of them. I think they're a great way to manage arthritis, especially in people with comorbidities. And when you're worried about giving them oral medications, they certainly should be in combination with other treatments. I often use cortisone, once if they present with a big effusion and they're unable to strengthen or rehab or do very much. I think there's a lot of education that goes along with cortisone injections, making sure patients understand this is not a long-term treatment, and your focused use and what it's for and how it helps. I do like to follow it in older patients with sort of mild to moderate chronic arthritis. I like to follow the cortisone with the visco supplementation. Often I'll try the visco first, and if that's not enough, I'll do a cortisone. So you try to sort of do one a year, one every 6 months, and then the visco, and it kind of extends their treatment relief. Um, I prefer the injections over the long-term NSAID use for sure, especially in athletes who are often dehydrated in training, and the risk of GI side effects and other renal side effects is higher. So cortisone injections shown to provide short-term pain relief, about 6 weeks average, have a minimal effect on function and no evidence for long-term pain relief. And so, why do we do them? um, and so, they can be helpful. There's a clinical effect independent of the degree of inflammation present. They do seem to work very well temporarily to shrink inflammation when people come in with a big effusion. But they can also work when there isn't an effusion. The problem is they wear off, and then the effusion comes back, and you're sort of left with where you were. So again, it's not a long-term solution. Frequency, general practice, once every 3 to 4 months maximum. There's some concern for cartilage toxicity with more than 4 a year. I think there still haven't been great studies on this, and I think we don't know the clinical importance of this mild cartilage thinning that we may see with these numerous injections over a couple of years. So I think there's need for research on that, but the general take home is do as little as you can. And so that's why you can sort of substitute all the other treatments. A cortisone would work with physical therapy. You'd send them, do a cortisone, calm it down, send them to therapy for 6 to 8 weeks, get them on a little plan of more exercise, seeing if that helps long term. You can look at HA injections. It's really important not to just do a cortisone injection for everybody who walks in. You want to make sure you have a diagnosis and you're doing it to treat the diagnosis. Of course, you don't want to do it in case of joint infection or hemarthrosis or if there's cellulitis. So you really just make sure you know what you're injecting. And sometimes people come in and requesting it, but if you don't have a clear diagnosis, I think you have to be a little bit careful. Relative contraindications, so too many cortisone injections, coagulopathy, poorly controlled diabetes. So it is important to mention to patients that the cortisone injection can affect their blood sugar control if they do have diabetes for sort of a week or so, and they can monitor it a little bit more closely. Definitely, I'm more conservative in patients with diabetes doing cortisone injections. So let's talk a little bit about hyaluronic acid injections. I use these a ton. I think they're very helpful for mild to moderate knee arthritis. I think the evidence is sort of but anecdotally, patients do like them. They're harmless, they're non-toxic, and Medicare pays for them, and they're a nice alternative to cortisone. I think also patients can do them every 6 months as paid for by Medicare, and that kind of keeps them coming in, and you can keep an eye on them and kind of motivate them to do other things and not just take medicine or get knee injections. So hyaluronic acid is a high molecular weight polysaccharide that's present in the cartilage and the synovial fluid and acts as lubrication and shock absorber. Normal adult knees have a couple mils of it, and it slowly reduces as we age. It's synthesized by the synovium, and in arthritis, we lose hyaluronic acid in the joint. We lose viscoelasticity of the fluid. And the companies that produce this claim that hyaluronic acid can help the joint produce more of its own synovial fluid, which who knows? I don't think that's been shown, but there may be some anti-inflammatory analgesic effects. I don't know that it actually protects the cartilage. I sort of explain it to patients as it lubricates and coats the holes in the cartilage. It's sort of thick and it sits in the holes for a while, then it slowly gets absorbed. And when it's in there, it helps with pain, and thus it helps with function. There's no data for one brand over the other. It works longer than steroids. They say 5 to 13 weeks. Of course, effects like for steroids can be felt a little bit longer. Evidence is very heterogeneous depending on the studies, depending on the degree of arthritis. There's a placebo response for sure. There is a risk of pseudoseptic reaction depending on the type. It's higher in certain types. I've not used Synvisc a lot because when I trained, just the people I trained with didn't like it. I was told Synvisc is linked to formaldehyde, and some joints react to that. And the more times they get Synvisc, the higher the risk of the reaction. And I've seen a few of those pseudoseptic reactions, and they're not fun to manage. Patients are in a lot of pain, the knee swells up. So I tend to stay with the more benign sort of plant-based ones. Less likely to benefit. Age, I think, it depends on the arthritis, but severe joint space narrowing for sure. I think when people come in with severe arthritis and they just want to try anything, I'll counsel them. We can try it once. It may help a little bit. And if it doesn't, then we don't do it again. If it helps, you can do it again in 6 months. And so there's been uncertain recommendations over the years, and now it's a recommended level 2, conditional. So again, you sort of try the lifestyle things, physical therapy first, and topical NSAIDs, and then you can move down the chain. It's indicated for the management of osteoarthritis, especially if there's comorbidities affecting medication use or failure of oral medications or topical NSAIDs. It works very well in mild arthritis for sure. Works well in patellofemoral arthritis, I've found, especially mild. So what about cutting edge treatments, PRP, stem cells? What is platelet-rich plasma? I'm sure everybody here knows that it's the volume of plasma with a platelet count greater than that of whole blood. So the platelets are concentrated in the centrifuge, and platelets are the key because they have growth factors present, and that's sort of the key to this working, is the growth factors, and the concentration of these growth factors, I think, has anti-inflammatory effects and helps with pain. And so the studies are starting to kind of trickle in. There haven't been any great studies looking at MRI changes or long-term outcomes, but especially for knee arthritis, PRP does seem to be helpful. And there have been several studies comparing it to hyaluronic acid, and sort of short-term effects seem similar, and the PRP effects seem to last a little bit longer, up to 12 months. The ones that I've read, the effects are better. And then when people fall back, they fall back not as far as down as they were. And there's very little risk of adverse effects. I think, pain with injections and pain from the injections has improved because the centrifuges and the separation techniques are so much better than it was maybe 10 years ago. People don't seem to have many side effects from injecting it. And this was a nice double-blind randomized controlled trial comparing the effects of hyaluronic acid versus PRP for knee arthritis. And you can just see timeline, the PRP worked better and for longer than the HA in this study for mild arthritis. So there were significant improvements favoring PRP over HA. Here's another one that was randomized, only 50 patients. They treated with PRP versus HA, and they didn't find any big difference in pain scores. But there were other changes in patient outcomes favoring PRP over HA. I think, the big thing is PRP isn't covered. So in those with PPOs, I offer PRP because we have HA covered for those patients. Blue Cross Blue Shield, they don't like to pay for HA, so it's expensive. PRP probably works better and is a little less expensive. So I sort of start with that in the younger patients, and then the patients who have Medicare, I'll start with HA because it's covered, and then depending on their response to that or their desire, we'll discuss PRP. Again, the younger patients probably have less arthritis and respond better. There's always been sort of controversy since PRP came out about how many injections do we do? Do you do one a week? Do you do one a week for 3 weeks, or do you just do one? And I think the single injection is probably as effective in pain improvement based on different studies. It's still a little bit unknown. And so we're talking about leukocyte poor PRP. And so in summary, level 1-2 evidence, likely beneficial with leukocyte poor PRP for joints. The effect size is small. There's no long-term data on the natural history, no MRI studies still showing cartilage growth, but hopefully that is coming. Again, just another trial showing mild benefits with PRP, minimal side effects. The big one is the cost, and it seems to be pretty benign and can be quite helpful. Stem cell injections. So potentially mesenchymal stem cell is a type of cell that could theoretically differentiate into different structures, cartilage, bone, tendon, and may lead to targeted regeneration of those tissues. And we get these mesenchymal stem cells from bone marrow and fat. There still aren't great studies on this. There's so many variations in the different concoctions of how we get the stem cells and what we do to them, and there's no controls. And then there's inconsistent reporting of how they're formulated, how they're injected, how long they're kept before they're injected. There's just a lot of variation still, inconsistent injection protocols. So it's a little bit early, I think, for stem cells still. So in summary, we try conservative management first, lifestyle changes, activity modification, assisted devices, canes, walkers, walking poles, rehabilitation, medications, injections, surgery comes sort of after that. I'm sure you're all familiar with this, that from the New England Journal of Medicine, 2008, that looked at knee arthroscopy versus nothing for meniscus tear and knee arthritis, and there was no difference at 2 years. And we're not talking about knee arthroscopy, so I'll skip that. I just wanted to talk about this one case that I think you'll see is kind of interesting. This is a patient I had treated for a long time, but he was a very avid elite athlete, and I think he came in once in his 40s, and he had a small chondral injury, and then he disappeared for a while, and he was fine. And he started coming in the last few years, and he has since moved to Colorado and comes back for treatment a couple times a year. He's now 66, avid skier, mountain biker, retired. So that's all he does, and has been for a few years, and has been aggressively skiing for a long time. Has a history of left knee PCL, MCL around age 50, not that long ago. The right knee chondral injury was small and mild, and has had some mild intermittent knee pain over the last few years, sort of progressively increased, especially as he skied more. He has a son he skis with. Skis 75 to 85 days a year, mountain bikes all summer. He's pretty hardcore. He used to do a lot more strength training, and now he's struggling with that. So because of the pain. So if, when you first meet him, you think, wow, he looks pretty good. And then you see his x-rays and that left knee has been like that for several years. And it's amazing the things he can do with a knee like that. I think he did have a surgery consult once a few years ago, and they told him, don't do anything yet, but he's very anti-surgery. So he kind of presents to you like this, and you're like, how do we manage him and make sure that his knee isn't unstable, knowing what he does? And he skis steep stuff, hard stuff, 100 days a year. How do you manage that, and how do you take care of him and sort of also try to prevent harm? He's tried topical NSAIDs, they don't work. Strength training is getting more difficult because he has more pain. He's extremely functional though, high level athlete. He does take oral diclofenac through the winters when he's skiing. Activity modification for him is biking in the summer and not skiing, so that kind of gives his knee a break. Each time he comes, I sort of try to introduce more interventions. So I suggested an unloader brace last time, which didn't go over so well, but we got him set up for a soft one, and more worried about the knee sort of giving out or having pain all of a sudden that really inhibits him. So we sort of try to do the strength work, the mountain biking. He does visco injections, and now he's added PRP and thinks that really helps him. We've limited cortisone over the years. Really only, I think he's had it every 2 or 3 years, not very often. And then this time I convinced him to see Dr. Ward when he comes, just to talk about the future. But the question is, when do you intervene with him, and how aggressive do you get? I think we can probably stop there. These are just other cases and some spine stuff. Or we can, I think we're more knee. So this applies to kind of all arthritis. That cyclist, here's one more. 77-year-old male presents for the first time with bilateral knee pain, mountain biker, and plays tennis and paddleboard. All of a sudden had pain going downstairs, and with tennis, sort of on and off for the last few years. He had a history of a meniscectomy, has a little bit of instability, but surprisingly is very functional. He had some moderate effusions, was stiff. I can't read this because I have something in the way, but and then on x-ray, severe patellofemoral DJD, another case of, well, the x-ray looks way worse than the patient acts. And so we just managed him with, I think, cortisone 1 in combination with some physical therapy and some activity modification, some aids, and try to get him biking. And then we were maybe going to consider visco. But yeah, another one of those cases where you look at the x-ray and you can't believe they're as functional as they are.